We all know that early detection is the single most important determination in improving patient outcomes. Bako Diagnostics remains committed to supporting you in your role as the first line of defense in the diagnosis of conditions of the lower extremity. Bako Diagnostics, helping podiatric physicians keep America on its feet.
Hello, everyone. Welcome to Dean's Chat, where we discuss all things podiatric medicine. My name is Dr. Jeffrey Jensen. I'm the Dean at the Arizona College of Podiatric Medicine and the host for the Dean's Chat podcast. Once again, I'm with my co-host, Dr. Joanna Ritchie. Hi, Joe.
Hey, Jeff. How you doing?
I'm doing fabulous. How was your weekend in Arizona? I'm in Minnesota, so it's not as hot here.
Yeah, weekend was good. We had talked about things that people don't know. I'm a Girl Scout troop leader for a bunch of daisies. So we had our first meeting this weekend. We had 11 6-year-olds, which is fun. It's just fun, but it's total chaos.
So then you come back to school to get a break.
Yes.
All right, that sounds good. Well, we have a phenomenal guest today, Joe, from Michigan, Dr. Brian Loder. Welcome to Dean's Chat, Dr. Loder.
Oh, thank you, both of you. It's such a pleasure to be here. I'm excited to participate and just looking forward to talking to you both. Thank you.
Fantastic. We have a lot of good things to talk about. Brian, if it's okay with you, let's go first names, Brian, Joe, and Jeff. Is that all right?
That's great. Yeah.
All right. Let me give you a little more formal introduction, then we'll get into it. Dr. Loder did his undergrad work at Stony Brook University. He went on to the New York College of Podiatric Medicine. He did his surgical training program at the St. John Macomb Hospital for podiatric residency. He is currently the fellowship director at the Michigan Minimal Invasive and Reconstructive Foot and Ankle Fellowship. He's also an assistant professor at the Michigan State University College of Osteopathic Medicine. He's gotten more and more involved with the American College of Foot and Ankle Surgeons, especially with the minimal incision techniques. We got a whole lot of things to talk about today, Dr. Loder or Brian.
I'm excited to share whatever I can, and I'm excited to learn from you guys too.
Well, we were discussing a little bit earlier, the hot ticket in our profession right now is fellowships. And if there's another equally hot ticket, it's MIS surgery. So I think, well, we hit the jackpot here bringing you on Dean's Chat. Thank you.
Thanks.
Let's talk about the fellowship. So many of our students, even in school, they're talking about 3 years of residency and whether or not they should do a fellowship. Would love to get your insights on your fellowship and fellowships in general.
Yeah, I was excited to start the fellowship as I started to wind down the residency program at Henry Ford, and knew that I wanted to teach at just a little stronger level, a little bit higher level, more of a mentoring program than anything else, because I think that's extremely valuable. That's the exciting thing about fellowships. It is more of a mentoring than it is a residency program. You have to have the ability to give information to these fellows about practicing, about life, about how it fits in, about family balance. It's just not bang in and bang out cases. There's a lot of levels, and I love doing it. I love teaching. It is my passion.
That's great. One thing I didn't mention is you were the residency director at Henry Ford Macomb Hospital for almost 20 years until January. So you needed something to transition into. So you might as well be a fellowship director.
Yeah, it was planned. I saw the hospital started to less support the program, and I saw the changes on the wall, and I could not imagine going another 10 years in practice without teaching. So I had to put together something that would satisfy my need to teach. I've been teaching podiatrists since 1995. I was part of the St. John faculty till 2005 when I opened the Henry Ford program. I was the original developer of that. And it was great for me, but it was just time to move on to something a little different. And I am so excited for it.
Good. Well, let's kind of unpack the fellowship program. Joe, your thoughts before we move on with fellowship and the intricacies of a fellowship and curriculum and things like that.
Well, I have to say, I really love what you said, Brian, that it's not just like a year of training. It's actually so much more than that. And the fact that you talked about it as this mentorship relationship, again, I want to sign up. Can I come do your fellowship? Because again, it's
next year.
Yeah. Jeff, can we talk about a leave of absence to go learn some new techniques? So, because I think this is also one of the big questions out there, oh, do I need a fellowship? What is it going to provide for me? And I think it's interesting, as we've had several different fellowship directors on, getting their individual take on what fellowship offers. So could you talk a little bit about your specific program for those that are out there curious about fellowship, wanting to know? And then if you could also kind of talk about when is the right time to start applying and kind of making that transition for residents, if that is something that they do want to include in their future.
Yeah. Well, first of all, I think the best time to determine whether you want to do a fellowship or not is as your program evolves from the second to third year. We all have, the buttons that we want pushed that are going to make us satisfied, that are going to make us happy professionally. And it's not for everybody. I always say that fellowships are not about need, they're about want. Not every student needs one. And there is a lot of discussion on this on LinkedIn about, why do we have fellowships? It's just another year of training. We can't make that decision for a student. They have to make the decision of, do I have the confidence to take this person's foot, leg, and life in my hand? Or do I feel like I need an extra level of confidence to do that? And the people who should be doing fellowships or should be teaching fellowships are the ones with lots of experience in mentorship, ex-residency directors, ex-faculty from programs who know how to teach and bring that information to the level of the students so they can feel satisfied. Our program is pretty much 2-on-1, the fellow with just 2 faculty. They're in our face all the time. And it's funny, the resident I have now graduated from a program in Michigan and came in. He had accolades all over the place by his faculty. Great, knowledgeable, super hands. I'm starting to think, why is this guy here? First day he shows up, he comes up to me and says, I have never felt dumber in my life than I did on day one because I don't know half of what I thought I knew. So, that in itself tells me we have a perfect relationship together. He wants to learn. He was modest about his education. And I just want to feed. I just want to give them the information I have. It's kind of a legacy thing. I only got a couple of years left on this earth. I want to make it right.
I think that's interesting because you're right. A lot of students that came through our school, they don't know if they want to do fellowship. Then I start fielding calls when they're at the end of their first year, like, what should I do? I'm not sure if I'm prepared or if I will be prepared. Is this just kicking the can down the road before I get a real job? And I think it's very individualized, like you said, Brian. And it's not for everybody, but if you want it, and really it's the only time in your life when you're going to have that opportunity to extend your training. I'm an advocate for getting as much training as possible, so it makes sense to me.
Yeah, and that's it. It's the last chance, right? The last before you dive into the pool, right? And just to double check if you're a good enough swimmer to handle it, And I love that they have a choice. I'm part of the fellowship committee with ACFAS, and so one of the things we're discussing now is, are they having to make the decision too soon? This is not a decision. Some fellowship programs take people in their first year. You don't even know what you want in your first year of residency program. So I really like to see it later, a little bit later, so they understand that as they hit third year, they're not getting the boxes and the buttons met, and they want to train more. It's hard for a first year to make that decision. It really is.
Well, I know this year for sure. I don't know if you had the same experience, Joe, but I was getting calls from our students and that are currently second year. They were second year residents, and they were being asked to interview and make decisions on fellowships while they were still a second year. Is that they're in demand? So I understand how it works. Is that how your program's working? Are you giving them that opportunity pretty early?
Yeah, we interview most of the ACFA fellowships interview sometime around March to June and make their decisions from about June to September. I have a pretty unique fellowship, so if someone wants to learn MIS, they're jumping on that boat pretty early. So I had a lot of second years asking me and wanting to be signed up way before I thought they should, but we've already accepted our 25, 26 fellow. I accepted him back in May.
Okay. That time frame is what I've been accustomed to.
Yeah, I would like to see it a little later, but it's a very competitive market too. Students don't want to wait around. Residency programs is competitive, but at least you're going to get something, right? There's only 50 something fellowships, and there's way more applicants.
Right. That's interesting. What do you attribute the prevalence of fellowships to being? I mean, it's not 10 years ago, we didn't have these kind of fellowship opportunities.
Yeah, it's a little mixed. I think that we trying to get an understanding on fellowships, whether they should be more specialized training and not just another year, right? But yeah, but the problem is again, not all residency programs are equal, and that was probably the #1 driver for me in Michigan. We had 14 residency programs in Michigan, counting my program that I was at. Ours closed when I resigned, so they transitioned students out and they don't want to have residents anymore. But the #1 driver for me was I have a whole host of programs in my state to feed a fellowship. Let's just design one, right? And the funny part is next year's fellow who's coming, he's from Miami. So he's not even from Michigan. So I didn't even pull from Michigan. I'm pulling nationally now, which is really cool.
Joe, you've seen the transition over the years into more fellowship training. What are your thoughts?
Yeah, and it's been really fun, like I said, to have a couple different opinions out there, but there seems to be some underlying themes so far that we've seen with all the different fellowship directors. And it really is that idea of it's not necessarily a need. It really is a want, and wanting to also kind of establish that relationship with someone that, like Brian said, like, this is different than residency where you have, 19 attendings. Like, you're with me for a whole year, and like, we are going to kind of embark on a mentor-mentee relationship. And what I would love to kind of transition, if it's okay too, is talking a little bit about, in your particular program, Brian, some of the MIS techniques and kind of how that came about in your own practice, and then how you've seen that training evolve over, I don't know, the last 5 to 10 years. I just had students asking about this. Like, is that just something that I can expect in every program, like every residency program, that I will get MIS experience? And it was like, no, not necessarily. And then are there fellowships then? So this idea that fellowship actually is also serving in this subspecialty or niche area of the surgical profession. So I'll throw the ball back to you, Brian, in terms of how did MIS start and what does that look like in your career?
Well, I'm going to date myself, Jeff, and like you said, I was I was in New York during the 1980s and 90s MIS boom, where you saw on the billboard, have surgery at lunch, go back to work at 1 o'clock. And I was there in our clinic in New York, and I saw some really, really terrible stuff, and it was scary, and I'm glad it went away. I'm glad it went away. But always in the back of my mind was that this is still something extremely valuable to us in podiatry. Incisional placements that are small working windows, it's very valuable to reduce. We all know that even basic hammer toes swell forever on an open technique. Our foot surgery swell because of the dependency and the function that they are. So it was always in the back of my mind that this was something valuable. And then probably in 2015, I started to question whether I ever wanted to do a bunion again, because the outcomes are just so poor, right? And the recurrence rate is so high. And, you do one side and the patient never comes back for the contralateral side, and so you're like, I'm going to give up bunions together unless I find another option. And at that time, Europe was publishing articles. Redfern and Vermoir was publishing their articles on the MIS bunion. And I said, this seems something for me. So I started it way before the instrumentation came to United States. And then I had the honor of working with Redfern and Vernois back in 2017 and learning from them directly. And that was it. I just fell in love with the fact that, one, I could reduce the trauma, reduce the strain and soft tissue envelope. And number two, I hate suturing. So I never had to do that, right? I can't stand suturing. So anything that I could do to avoid suturing, and that's why I had residents for so many years, is I just don't want to suture anymore, right? I just walk out of the room. But the fact that I can do surgery and not suture and get a great result was very valuable to me. So I just did something that most people my age and in my profession did. I just put my head down and I committed 100%. It's like, if I'm going to do this, I'm going to do this right. Now, I really love that it is built up, that there's a lot of mentors out there and there's a lot of people to help. And every time I lecture, I give my email, my cell phone, call me, send me pictures. I'll help you with this. But back then, I was flying solo. I didn't have a lot of people. I had to email Joel Vernois in France and wait, 2 days for him to get it and barely understand if he called me what he was saying. I had to talk things out with people who I didn't know, I didn't have a comfort level with, and they were fantastic. They were just open to bring this to the United States anyway. But no one has to fly alone anymore. I mean, we have ACFAS is doing lectures on it. Every local state, I'm getting called to go lecture on it. We have fellowships now. We just put an entire MIS into clinics of podiatric medicine coming out next month. I'm publishing. I'm literally have 3 or 4 articles at any given time that I'm working on. So it's just starting to really start to open up to everybody.
That's neat. And then you're working with ACFAS, you said, on a MIS track. Is that going to be available in March next year in Phoenix?
Oh yeah, we're going to have multiple presentations. It was nice. There's just a nice group of people that I work with. Brett Abick is fantastic. He always gives me credit. I trained him the first time. He tells a great story about he walked away and said, I ain't doing this. And then went home and chewed on it a little bit and said, I'm going to do this. Brian Burgess is a big supporter. He's involved. He's going to be in ACFAS. There's just so many. Noman Siddiqui, he's fantastic at this. He's great sitting on the podium with him. He's a bright, intelligent man. All these people are so nice, so bright, and so willing to just open their techniques to anyone. I think that's a nice thing about MIS. We just want to spread the word and teach it because it's still smoldering a little for our own, we want it a little bit bigger.
It's interesting, Brian, because I interviewed Ryan Scott, who's the fellowship director down at CORE here in Phoenix.
Yes.
And he and I were looking at some x-rays, and when you were looking at the bone-on-bone overlap of some of these MIS procedures, there was none, basically. And there was a screw going through it. And I asked Ryan, I said, 15, 20 years ago, if you put this x-ray up, people would be like, you got to be kidding me. And he's like, yeah, but they're healing and they're doing well, and it takes a while to remodel, but it's working. What was your early thoughts when you started to see some of these head procedures that were moved over so far and it was not sure if it was going to heal?
I mean, I followed the comfort level of the originators, and I, call him by myself with not a lot of support. These x-rays leave you and go someplace else, and all of a sudden they're like, this is not surgery. This guy did something wrong. So that's one of the other reasons we want the word to catch on, is because we don't want to look like lunatics very long. We want the support. But you're right. When we first did it, it was a lot of, yeah, I'm following your recommendation, but this is scary. Is this really going to heal? So you do a few of them, then you don't do any, and you wait to see how the healing is, right? And then all of a sudden you're like, hey, this works. And then you repeat the model over and over again, And I will tell you guys, the patients absolutely love it.
Yeah.
And they complain all the time that they can't find anyone in their neighborhood.
Yeah.
The average drive for an MIS case in Michigan, and I have been teaching for 4 years, is an hour and a half. So my patients drive at least an hour and a half or longer to come get these surgeries. And that's great, but I'd rather teach someone else in their neighborhood to do it, right? And let them save the gas money, because it's expensive these days to live. I do a lot more of my visits virtually now after the surgery, because I just try to keep the patient from having to drive so much.
And if I can jump in real quick, Jeff, because this was one of the things that I think really piqued my interest when I first started seeing a lot of the MIS reconstructive stuff. So I have a little bit of a bias that we were doing some of the MIS trauma stuff. And again, to your point, Brian, like, it's a little bit scary and you're like, is this really going to work? But then you see the outcomes and you see where the benefits really actually can be for patients. And then you start to be humbled by where the appropriate indications are and maybe who it's the most appropriate for, and, watching the evolution there. And so I was very hesitant, we'll say, about, and with the reconstructive part, because this is not trauma. This is, I'm opting into this. I am electively signing up for this. But what I really appreciated from the community of the surgeons that were talking about it is the honesty, is the transparency about what your experience has been. The ACFAS track in LA was the first time that I feel like ACFAS really, and maybe I might be incorrect on this, but that was the first time maybe that I paid attention at ACFAS to where MIS was being discussed. And, it was such a beautiful presentation. I believe she was Canadian, an orthopedic surgeon that was talking about deformity correction. And like, if the biggest hangup that everybody has is really the X-ray, like, who cares about we don't care about the X-ray so many other places. Like, what is it? If that's really the only hangup, then, we need to change the conversation. But then immediately after that was a panel, and I think it was Blitz, Siddiqui, and it might have been you. And I'm sorry, I don't remember who there was 3 people, and you were talking about complications. And again, just full transparency. And as soon as I heard metatarsal explosion, I was like, yep, nope, I'm gone. Like, thank you, but no, thank you. But again, at watching this evolve over time, and I mean, that was almost 3 years ago now, and building this community. And I know you and some others have really worked on supporting docs that are wanting to do this, because to your point, you go somewhere else and these X-rays end up in someone else's hands. And depending on who is making these judgments about what was done, you may end up in a situation you didn't expect to. And having somebody to back up what you're doing, having journals now to help back up and support with not just expert opinion, which is valuable, but actual clinical studies, Bradley Alberts just put out a paper, maybe not just, but with the methylene blue, like showing how
Yes.
like this is the stuff, right, that helps really support the movement with academic literature and support evidence to say what we think works is working. This is why. And so again, building this community when patients want it, when the future of surgery is going to be smaller and smaller technologies in so many capacities, I just feel like this is the future of surgery. So my question for you, after all that very long-winded discussion,
which was wonderful, by the way,
is as we are teaching students surgery, and I talked to Mike Downey about this too, I feel like to be really good at MIS, you have to understand the anatomy from an open perspective. How do you think we start to marry teaching MIS and the success of MIS, having had a background of open, as we start to evolve to they're not going to maybe have that open experience because everything's going to go, in my opinion, it's kind of where we're going to go. Do you think they're losing something by not having open training?
So I have a very strong opinion on that. I think open training is extremely important. And let's just go today. Go today. So we had my goal is to try to do any surgery MIS, right? And I'm training the fellow. He's early on in his career, and we have a triple arthrodesis, which was fairly rigid, but I would traditionally do that all MIS. And it's very boring for the resident if they don't have experience to deal with that. And it was a very hard deformity, very rigid. So we split the difference. I said, we're going to do an open procedure, but you're going to prepare the joints with the burr so you can get the feeling, how much they debride, how much tension you have to put in them. You don't get to use a saw. You have to use the burr. And everything you do is with the burr. And I want you to see what you do and what you accomplish with it. So when you don't have the skin out of your way and it's closed, go by feel, right? And so we start to develop that, at least at my program, and I think this is very important. I think that the MIS should be held for the third-year student, resident. It should be someone that is not just dabbling in it. They should have experience, and every program can find someone who they lean on, who is a teacher. I opened myself up when I when I resigned from the residency program to any program in the state they want to send their residents to learn MIS. Until I got my fellow, they're welcome to. No one took me up on it, but that's okay. I got to see how valuable and how much I love to teach when I went 8 months without teaching. I really enjoyed and knew what I missed. But we start with MIS as the purpose of the end. But if I have to open and teach something and use that as a learning experience, we do. So it's very valuable to understand your anatomy, your biomechanics of anatomy, your functional mechanics, your functional anatomy before you ever start using a burr. And I don't recommend anyone just block out the open procedures, because you have to be able to do it from time to time. You know, I've yet figured out how to repair a peroneal tendon with a burr. I'm getting close to carving a turkey though, so I'm getting good at that.
That's very insightful. I like it. Hey, if you don't mind, let's take a couple minutes or 30 seconds and give a shout out to our sponsor. It's Bako Diagnostics. We all know that early detection is the most important determination in improving patient outcomes. Bako Diagnostics remains committed to supporting you in your role as the first line of defense in diagnosing lower extremity pathologies. Bako Diagnostics, helping podiatric physicians keep America on its feet. Thank you, Brian. I mean, Bako is so good to our profession and our students and our educational opportunities.
I love Bako. I use them all the time. I love them. Yeah.
Well, you know, when you said that communities need a doctor to lean on for expertise, I thought, oh yeah, we lean on Bako Diagnostics all the time to help us with dermatology and pathology. So that's what reminded me to do it. I love your philosophy there, Brian, knowing how to do things open and then giving a fellow an opportunity when it's open to use the burr instead of the blades. That's brilliant teaching. What a wonderful opportunity for him or her. Whoever it is.
Thanks, Jeff.
Joe, your thoughts.
Yeah. So if we can kind of unpack that even more, as you have watched this evolve and as you have made that own transition, and actually let's start with that. When you were making the leap and you said you just decided to commit, how did that like learning curve work for you in terms of like, how did you help sharpen your own skills without having someone, you had people that from Europe that you had talked about that did help, but like, what did that look like? How did you perfect your skills?
Well, I started with percutaneous, pull the burr out, open it up and see what it looked like. Right. And so I did that for about a dozen or more, maybe 20 cases. So I had a feeling of what was I doing harm to the tissues, the tendons, the capsule. Yeah, they show you the burr, you put it on your hand, it doesn't cut, but it can get tangled up in soft tissue if you linger too long. And so that was the biggest thing to me. All of a sudden I'm like, wow, I didn't do any damage, right? Is just, and the bone was cut very, it wasn't as smooth as at the beginning as a saw, but even when I started a saw as a first year, I wasn't very smooth then either. So, you got to get that skill set up. But I advise everyone who doesn't have someone to lean on, who can't do labs, because again, I did one lab for 2 hours and was sent back to my community and said, all right, go knock him dead, right? And that's just hard with MIS. So I had to prepare the patients, possible open MIS case, and then I had to open it and work in that realm. And I started to develop a better skill set, and more importantly, I was comfortable, right? Because I think the learning curve is probably the wrong statement, because we all know how to do surgery. I think it's a comfort curve. I think the curve is a comfort curve, and when you get comfortable, where you know that where you put your cut is going to stay there, it's not going to wander, your screws are going to get the right direction every time with the wire. I always teach the fellows and the residents, more pokes equal more pain. Just keep on jamming that wire in, and it's just going to be painful to the patient. So you got 1 or 2 shots, or I'm going to sit down and do this for you, and we're going to let's get together next case and try it again. But I'm certainly not putting my patient in harm for the teaching. And I've done that over the years. I figured out where they can put me in trouble and where they can't. And I just try to keep them out of that trouble zone and work with them that way.
I love that. And again, is as you work with early learners and why I think that the idea of MIS in a fellowship kind of niche just makes so much sense too. You go through your standard training, you get a lot of open exposure, you get much more comfortable with, and I loved the comfort curve. I'm going to totally start stealing that. I'll totally give you credit, but I'm totally going to start using it.
It's all yours.
Yeah. Because you're absolutely right. It's very much like what people are comfortable with. but have that opportunity to build that skill set and then come and apply it in a new way. And I love that. And I think too, as you had talked about that, ACFAS is getting more involved in doing some of these hands-on courses as well. What are your thoughts in terms of the evolution of how we teach surgeons or train surgeons, those that are out in practice, new skills?
Yeah, the hands-on lab, the cadaver labs, you can't really do very much with a bone model. The MIS is unique in that it requires a focal pivot point. The tissue is really good for that. You can't do that with a bone model. But, this is where, and we curse industry a lot for the pressures they put on this, but industry is helping us with this because these labs are expensive. Yeah, they have an ulterior motive, use our product, but they're supplying us with the cadavers, the space, and as many of these industry labs you can go to. Because the thing about MIS is the equipment is all the same. The technique is all the same. It's maybe the screws are a different color, right? Or the jig is a different, but the technique is always the same. And once you leave there, you can use whatever equipment you want, whatever hospital that wants you to use, but you gain the knowledge and the technique. And so I would just tell everyone, if they want to learn MIS, to go to as many industry labs and ACFAS labs as possible. 2 or 3 hours at a pop, do 3 or 4 of them, 12 hours of training. You should be ready at that point. But I would not want anyone, my family, to have their surgeon do a 2-hour lab and have surgery on Monday by that same person. I think that's just a bad idea. Bad idea.
It's interesting because we've been talking about the CME models, Brian, over several of our Dean's chats, and it's becoming more and more evident that the delivery of information can be done just like we're talking right now. And then the hands-on experience can be done with these companies in their labs. It'd be kind of a nice marriage of information and experience. And it lends itself to that.
I agree. I mean, there's a lot of good people putting together virtual meetings where you get the basic of something. We did one this couple of months ago just on MIS. It was a great weekend virtual meeting, and it was you get a lot of knowledge, and more importantly, the viewers can decide, is this for me? Do I want to go any farther on this? Because we all have families, we all have jobs, and, flying across the country is nice, but do we really have the time to go into a lab if we really don't think it's for us? And so a nice virtual meeting, you can see some x-rays, you can talk to some people, you can get their feedback and decide, all right, I like this idea. I'm going to go deeper into it. And that's what I did. I found it, I loved it, and I just went deep. I went head first into it, but right now I barely do any open cases anymore. When I do, I love it, but everything is, to me, is viewed as, is it possible to do this minimally invasively? The fellow was completely blown away today when we did a 4th, 5th intermetatarsal arthroplasty, cuboid 4th, 5th metatarsal arthroplasty with interpositional tendon graft, all MIS, and he's like, I couldn't even imagine you could do that. And I'm like, the sky's the limit. If you have the technique and there's a procedure you like, you can work it out.
Very good. Very good. So I like your mindset. What other areas of your life have you kind of implemented? What do you like to do when you're not doing surgery?
Oh, I'm a big family man. Me and my wife, we love to go for walks. I have 2 beautiful puppies. I have 2 sheepadoodles that are just fantastic. We just got done. We're training them now, taking them out to restaurants, taking them in walks. Me and my wife love to go for long walks and exercise. We're going to pick up golf this winter. I was never a big golf person because golf for work, where you're trying to meet people, just doesn't work for me because I'm not good at it. So I need to focus on learning it first. I have 2 beautiful children. We spend a lot of time with them. It's just we're just very active. Me and my wife have a very active schedule, working out and exercising, going for walks, and just enjoying life.
Hard to beat that.
No, you can't. That's great.
I'm an easygoing guy. I don't have very complicated hobbies. I don't make fancy furniture. It's MIS or nothing for me, really.
Well,
I
when
make that joke to students that I don't have a dial, I have a switch. It's like I'm either on or I am off. And like on all things, it's like I don't know how to dial. I'm just like a switch person. So
Yeah, my wife is that way. Everything gets 100% or nothing. So,
yes.
we when we get home in the evening, it's decompress and just peace and quiet. I love a good cigar, a little sip of a good bourbon on the deck. That's a great evening to me.
and you're going to ruin it taking up golf.
Right? Exactly. Well, I always truly believe that golf was a good waste of a good walk. But I'm gonna try to learn it this year because we want to do, both of us have bad knees. So tennis, is out. Pickleball may be in. We may be able to do that. That's a new thing coming out,
Mhm.
So
Yeah, pickleball has taken over the world, man.
oh my God, big.
Yeah. And even more for our patients who want to get back and recover quickly. And so, yeah.
Yeah, MIS plays a big role in athletes. Big role in athletes.
Definitely.
Yeah, big role.
Very good. So what do you see as the future of 10 years from now? MIS surgery for bunions, is that all we're going to be doing, or is there going to be indications for other types of procedures? What are your thoughts, Brian?
So there's not a bunion procedure you can't do MIS. And I believe it's going to be broken down into two things. It's going to be an MIS capital fragment osteotomy and an MIS lapidus. I mean, those are pretty much we're done with the articles that say 150 different procedures for a bunion. I don't know how many times I've read that quote, but by 2000, I said this back in 2019, by 2030, we're going to have two procedures for bunions, and that is MIS capital fragment and lapidus. That's what I believe. I think the entire training, everyone's going to jump on board in the next 2 or 3 years, because ACFAS is really putting pressure. They're going to start doing more regional labs. It's going to be at every year at the conference. They have bought in. Joe said, prior to Los Angeles, it wasn't even mentioned or on any of the tracks. And it was big then. It was great then. Now,
Yeah.
Joe, I wasn't at that one. I was in the front row, and I know what you were talking about, but I got a chance to do a bunch of speaking in Tampa.
Yeah.
And that was great. That was
a really good track.
and we'll be in Scottsdale this year. So
We'll have to take him out to golf.
Yeah, well, I may be ready.
Yeah, if you want to golf, we're putting a group together, and you're always welcome. And when I golf with all the other deans, I make it very evident right from the beginning. I don't keep score. I drink a few beers and just have fun.
You're Jeff. Me and you are golfing together. I like that. I like your approach.
My version of golf is mini golf.
Mini golf. We played a fantastic mini golf course a couple of months ago. I think we were in Atlanta. It was an indoor course. It was fantastic.
Best kind of golf.
So, Jeff, part of my goal in life before, and I'm past that because I have this whole MIS thing, but part of my goal in life was a dean of a school. I always thought that I wanted to be an academic. So tell me what that is like. I know I'm reversing your podcast on you, but
No,
hey,
I love
this
it.
is so interesting.
I love it. So Brian, similar to you, I was involved in starting a residency, and I was a clerkship director, and the best part of my week was training residents and having students come through the program as clerks and externs. And I applied for a dean position, and I thought I knew a lot about education because we had started the residency program, and went through the CPME hoops. And then I was doing lots of research grants with the NIH, but I was not prepared with my first dean position for the accreditation hoops. I mean, it's very rigid. And the answer to your question is I loved it. I just loved being with all the students, but it was difficult. And that first year when I was in Miami, my family stayed in Denver because my son was a senior in high school, and it's the best thing we could have done because I'd go to work in the morning and I was completely engrossed in the educational process and all the accreditation issues that CPME puts on the colleges. And so I'd go to work, and then I didn't have anything to go home to because my family was in Colorado. I would just stay in and work. So it was a completely different game, and it wasn't anything that I would have ever anticipated, to be honest with you.
How long did it take you to get comfortable? What was your comfort curve?
My comfort curve, I think that once I realized that you had the basic sciences and then you had the fourth year clerkships, and our job was to intersperse the podiatric medicine track, the surgical track, the biomechanics track, and the general medicine track. Once you got all those tracks in place, that was crucial. But at the end of the day, and Joe and I have discussed this a lot, and with our faculty, admissions is everything. I mean, if you bring in a great group of students and they're very well prepared academically from their undergraduate experience, it makes a huge difference, because being a dean is, on one hand, you're in education, but on the other hand, you're in administration. And administration requirements are different than faculty requirements, because you're talking about budgets and you're talking about board scores, you're talking about residency placement, you're talking about expanding the program and how are we going to do it? You can't do it unless you've got good students. So
Yeah.
I learned early on, and Dr. Treppel told me this early on from New York. He said, admissions is the name of the game. And if you get that down, then everything else kind of falls into place, especially if you have great faculty. I mean, the faculty are phenomenal. And, we brought Joe. Joe, how long have you been with us now? About a year and a half?
Just over a year. Yeah.
Yeah. And she's teaching surgical courses. And I think that you need to have constant transition and bring in new blood and different ideas. And I think that's important to progress your program, just like residency training.
Oh yeah, it gets real boring if you don't give something new for the students to have.
Yeah.
And Treppel was my he was chief of surgery when I went through at New York. He was a great guy. Yeah.
Mike's been very good to me as a dean, especially when I started. And then also Mike was very instrumental in our college becoming a college, because we were initially the Arizona School of Podiatric Medicine within the College of Health Sciences. And Mike Treppel was amazing with CPME and helping us transition into our own college. And I think that really gave us equal footing with the other colleges in terms of students looking at our college and saying, hey, this is a reputable place to go. So it's always a transition year, and there's really no status quo, right? You're either getting better or you're getting worse. So you got to keep getting
right.
better.
Yeah. I got that. Yeah. I will tell you that I would open this up to you at no means of giving a commitment, but if I could get the opportunity to do virtual lectures on IAMAS to any of these at school levels, I would love to do it. All just out of the goodness of getting the word out. I would love to be able to do that.
What actually could be really cool, because multiple campuses have some interested faculty, I'm sure, would actually be kind of try to do a virtual and get all of the school, well, maybe not all, but whomever is interested, and do a multi-campus type event. If you would be open to it. I have a couple contacts that we can reach out and try to make that happen. And
I know that the individuals that I work with, like I mentioned, Bradley and Brian, and they would love to participate, just to be involved in that, to spread the word, because that's all we really care about, is spreading the word,
Yeah. Awareness is everything.
Yeah.
To your point, people can choose what they want to do, but awareness is huge.
You got to show it to them. You got to give them the opportunity. Otherwise, they're just going to listen to the word of someone that tells them it's nonsense.
Yeah.
Right.
Yeah. I had a great conversation. I'll keep the particular surgeon confidential, but who's very negative about the idea of MIS, and he had a whole list of reasons why. And I said, oh, I kind of felt the same way, and it's been really interesting to educate myself and kind of dive a little bit deeper into this. And I showed him an X-ray from LinkedIn that people had, and again, this is somebody else had posted, this was not mine. And all of the things that his argument, and it was just like, none of it was true. It was like, and he was just like, oh, like that moment of like, oh, maybe I'm wrong. Maybe I need to reevaluate what MIS actually means today in modern practice compared to maybe what my perception of MIS is. And so I love what you guys are doing on LinkedIn.
Yeah, I think that was the biggest thing for me, getting on social media, right?
Yeah.
I tell this funny story all the time. We're in Tampa at an all women's meeting and I'm sitting there, and a young lady is sitting here, and then my wife's sitting there, and I go over to introduce myself to the young lady, and I'm like, Brian, she goes, oh, I know who you are. You're famous. I follow you all the time. My wife says, don't tell him that. It was a great moment, but it wasn't. It was just funny that she said that. But that was the initial way to get the word out.
Yeah.
Now we need to get the technique out,
Yeah.
and you can't do that on social media. You
Mhm.
can't. You know.
Right.
Yeah.
To that end, Brian, Joe was instrumental in bringing arthroscopy simulators to our college this year through an ACFAS grant. And every day I walk by the lab, and the lab's empty if we don't have a lab going on, but in the corner, there's students playing on the arthroscopy simulators, almost like they're pinball machines in the corner. And they are getting technique and they are getting good. Joe, I was
They are
in
getting
there
good.
the other day
Yeah.
with a couple students, and they looked like they owned the machine. They were really doing well.
Oh, I love that. I love when students learn when it's not supposed to be learning time.
Right.
I
Yeah.
love that. I love that. I
And
would just peek in the window and watch that all day.
Yeah,
And it's
you
funny.
know what I did, Joe? I took a picture of the whole place being empty, and then I took another picture closer and up close because
Yeah.
it was exactly what you're saying, Brian. They didn't have to be there. Their
Yeah.
classmates weren't there, but every time I walk by, there's somebody in there playing on those simulators. So, what a cool way to get students to learn. You need to figure out a way to do that for MIS.
Yeah, yeah. Well, probably, that's the next thing is learning models. Some individuals in Brazil came out with one, and it's good work, but it's a one-time use foam foot. So after you make it, you can't, and so you can't reproduce it. But it would be so nice, and I think that world is where we marry with the virtual world. You know what I mean?
Yeah.
And it's all, image and virtuality, and you're doing your surgery in a virtual world with your hands and instruments. That's where that marriage is really good.
Yeah.
Good point. That whole generation doing video games and things, they have a leg up on us old guys,
But there's no doubt. There's no doubt. They're so good at it. You ever play your kids at video games? I get lost, right? I get lost. Yeah.
Absolutely. Absolutely. So Joe, anything else? What a fabulous discussion. MIS, fellowships,
Yeah.
training, surgery, simulators. Thank you, Brian.
Career transitions, lifelong
Oh my God,
learning.
yeah.
Yeah.
This is lined up perfectly, like, to what I enjoy doing, and that is just, you can't leave this career without leaving something behind. And things like this and LinkedIn and lectures and stuff I go to, it's just makes it all worth it that I committed to it. I struggled for years. It just makes it all worth it. I would do these on a everyday basis. They're fun.
And the support that I think that you provide, because to your point, Brian, like anytime I've ever seen something from you, there's always contact information. Having that support, because and I will just speak in the I language and I'll be fully transparent right now, but that vulnerable moment of, if you want to try to learn something new, kind of not completely on your own, but you go to a couple courses, you try a couple things and you're ready to do it. What's always kind of in the back of your head is, what if it doesn't go well, right? Like, what do I do in that situation? And so and again, I just commend all of the players that have been active on LinkedIn and active in these communities to support docs wanting to take this on, that you're not just flying by yourself. If something, were to end up in a maybe not so favorable light, you have support. Again, being mindful and appropriate with the technique, but it's not just because you're doing something that you become an outlier and now you're on your own and you have to defend yourself. There's a whole community of support now. And I think that really helps encourage more people to take on that comfort learning curve and say, I want to try this, and I'm willing to take the steps to learn it appropriately, get the skill and the technique to do it, and then be brave enough to embark on the comfort curve.
Yeah. When I started in LinkedIn, I started getting, on a regular basis, private messaging. These are my x-rays. Here's what I have, look at them. Here's my work. What do you think? Critique it. And 99% of the time is, man, that is awesome work. Great job. I mean, one time I had to say, you may want to take that back and refixate it. And he, to be the truthfulness, he called me the next day and said, I went back to OR, I fixed it. Thank you very much. I appreciate your input. And so to be able to do that across the country and across the world, I've had people in other countries reach out to me and we talk about cases. I just love that. I mean, that is something that you just not everyone has, and that's enjoyable.
That's so cool. And also, Brian, thanks. I mean, you and I have not met, and I just reached out on LinkedIn because I loved all your stuff. And I thought, hey, Brian, you want to come on Teams Chat? So I appreciate you jumping on without really having a relationship before. Thank you.
But we got one now. I'm going golfing
That's
with
right.
you, Jeff.
You got it. Now, I'm going to have to train up myself a little bit. Are you getting lessons?
We're going to get lessons this winter. Yeah, we're going to get
Maybe we
lessons.
just
So.
go to Top Golf. Maybe
Oh, we can do that because you could. They serve you beer.
exactly, and you can just kind of have a social and sort of golf it.
Yeah,
I look forward to it.
So I can assume that both of you will be at in Arizona, right?
Yes.
It's in your backyard, you know.
Yes.
Oh yeah.
Yeah.
Oh yeah. We're going to do some fun activities for alumni at the college, and our school's grown a lot and our lab's grown a lot. So we want to bring in our alums and show them all the fun things that have happened over the years to their school. So we're excited
Well,
about that.
I will tell you, and I don't mean to offend I don't mean to offend anybody, but we've had a handful of Arizona students at Henry Ford through my 20 years, and they have been absolutely sharp and bright. So you guys are doing a fantastic job preparing them. They are really top students. It got to the point where we're like, if we could just pick from Arizona and Des Moines and just select only from those two schools, we would be happy. Yeah. So, kudos to both of you.
And I should say that was unsolicited 100%.
100%.
Absolutely.
Yes.
All right, Brian. Hey, we're going to send you a Dean's Chat cup because you're going to need it before you go golfing.
I appreciate that.
And
is it a cup or a
It's a
beer
mug.
It's a coffee
You can put
mug.
whatever you want in it.
Love it.
It's big enough to hold a beer. I'll put it that way.
Awesome.
Absolutely. And to all of our listeners out there on Spotify and Apple Podcasts, please give us a 5-star rating and leave some comments. If you're watching our videos on LinkedIn, that's how Brian and I met. By all means, make a comment. And if you're watching on YouTube, please become a subscriber. And until next week, cheers, everybody.